give everybody a few seconds to join here. We've got about a minute before we start the webinar. All right, well, we have a jam-packed session for you here today, so we're going to go ahead and get started. Welcome to part 2 of our campus-focused webinar. Today, we're going to be talking about setting your campus telemental health program up for long-term success. And we are so fortunate to have you all join us here today. We really appreciate your time. My name is Danielle Lauder, and I am the director of the Northeast Telehealth Resource Center. And next slide, Arya. Just a very quick confidentiality disclaimer, we will not share your individual data and just want to make sure that you are aware of that. We'll keep that confidential. We do utilize your information to help share information out to you, et cetera, but just wanted to make sure folks were aware that we do not share your individual data. Next slide. So this telemedicine hack is hosted by the National Consortium of Telehealth Resource Centers. And for those of you who may have joined us in the past, you would know that we are funded through HRSA's Office for the Advancement of Telehealth. There are 12 regional telehealth resource centers. As you can see from the map, we collectively cover all 50 states and US-based territories, including the Pacific Basin. And we have 2 national TRCs, the Center for Connected Health Policy, which is, as you may expect, focused on the ever-changing landscape of telehealth policy, and the Telehealth Technology Assessment Center, which, as you might imagine, is focused on all the various options out there for telehealth technology. Next slide. So just a little bit about, again, if you haven't had a chance to join us in the past, the National Consortium for Telehealth Resource Centers had played an active role through the original sessions, telemedicine hack sessions, which were offered through the HHS and the Office of the Assistant Secretary for Preparedness and Response. And with all of the wonderful feedback that we got, we decided to continue these sessions moving forward. And we're asked, the telehealth resource centers were asked to continue this moving forward. So we will continue to offer additional sessions based on your feedback and need through March 2021. So stay tuned. Stick with us. Just a few tips and tricks for the webinar. If you haven't joined us before, your phone and/or your computer microphone have been muted, just so that we can hear our wonderful speakers here today. Please place your questions in the Q&A. You'll see that at the bottom. There's also a chat. Please reserve the chat for any technology issues, if you have an issue with the video conferencing platform, but we'll see and respond to your questions about the content much more easily if you put them in the Q&A. So please go ahead and do that. Attendees are able to adjust your video sizing if you'd like to do that, if it's more difficult for you to see. You can toggle, we do have closed captioning here today, so please take advantage of that if you need to. This webinar is being recorded, and you can find all of our recordings from today and from previous webinars on our website at telehealthresourcecenter.org or on our YouTube channel. Next slide. We are offering continuing education credits through our colleagues at the University of Arkansas School of Medical Sciences. And so that's just a little bit about them there. And next slide. All of these planners and speakers for this particular telehealth series, we don't have any relevant financial relationships or commercial interests. And this covers all of us here today. So next slide. And you can see all of the joint accreditation and credit designation statements here. There's a couple of pages of these. There's several offered here. Thanks. So if you have not participated here before and you would like to get credits, all you have to do is establish a free account for Learn on Demand. You can just click on that link, go through, set up your login, registration, another password to remember. We're sorry, but that's part of the deal to access this free content. So search for the topic that you're looking for and then just launch, evaluate, and click continue to print off your certificate. Next slide. Important note, all evals have to be completed by Thursday, December 24 in order to get those CE credits. So please don't forget that deadline, mark it in your calendar. Next slide. Just a little bit more information here and a reminder of that deadline. And there's some more resources there on Learn on Demand. And if you have any questions, there's contact information there, and you can always refer back to this slide deck for explicit instructions. Next slide. Very quick rundown of today's agenda. We have 3 wonderful speakers, and I know our moderator, Dr. Ramers, is going to introduce each one of those. So I'm going to keep rolling here so we can move forward. Next slide. So without further ado, I'm going to go ahead and introduce our wonderful facilitator who's been with us pretty much since day 1 with the telemedicine hacks. Dr. Christian Ramers is the Chief of Population Health and Director of Graduate Medical Education at the Family Health Centers of San Diego, a large federally qualified health center, or FQHC, system serving nearly 200,000 medically underserved individuals throughout San Diego County. He is board certified in internal medicine, infectious diseases, and addiction medicine, and is particularly interested in HIV, HBV, HCV, and service of medically underserved immigrant and refugee populations. He co-chairs the California chapter of the American Academy of HIV Medicine and has advocated for HIV, HCV care at the state legislative level. He served as a consultant for CDC-sponsored HIV, HPV, HCV educational projects in Asia and Africa. Since 2018, he has served as the Senior Clinical Advisor for the Clinton Health Access Initiative's Global Hepatitis Program, working to eliminate HBV, HCV in 7 partner countries in Asia and Africa. So I think actually we might have a couple of polling questions that we need to do just before we get started. So Ari, if I could have you pull those up very, very quickly, and my apologies for forgetting. So folks, if you could very quickly go ahead and answer these questions. We just want to know a little bit about all of you. So if you could quickly answer, let us know what is your current practice setting, then we will just let our panelists know a little bit more about us, about you. Lots of folks in college health and mental health, as might be anticipated. Great. And then some other folks too, primary care, et cetera. Great. So as the second poll question is, how long have you been practicing telehealth? Are you a newbie, or have you been at this for just a little while? We'll see what kind of responses we get here. Very quickly, so some relatively new folks in the telehealth landscape. All right, so that's great. That's very helpful. Without further ado, I think we're going to go ahead and turn it over to Dr. Ramers. Thank you so much, and we look forward to the panel.
Great, thanks a lot, Danielle. And if we go to the next slide, there we go. Good. So it's my pleasure to introduce our first of 3 speakers. Today, we're going to focus on campus telemental health. So Joy Himmel holds a doctorate in psychology. She's a licensed clinical professional counselor and registered nurse with over 30 years of experience providing mental health services in hospital-based inpatient units, community mental health, and in college health. She's a member of the COVID task force for the American College Health Association and is a site supervisor and board member with the American Association for Ambulatory Health Care. And before I hand it over to her, I would just really encourage you to be active in your questions. Go ahead and use that Q&A box. If you have things to share or resources, please use the chat for that. Take it away, Joy.
Okay, thank you very much for that introduction. Next slide. And I'm happy to be here and representing the American College Health Association COVID-19 Task Force and also AAAHC. Next slide. So what I'd like to cover are benefits and challenges of sustaining telehealth services. We'll talk about accreditation standards and how they apply to the telemental health service delivery system, and then some future directions related to mental health in the college counseling arena. Next slide. So this just shows the upward trajectory of internet use, and you can see that it continually has increased, and this stopped in 2019, so we can only imagine what it is now for 2020. Next slide. So I want to highlight a few studies related to telemental health. And in March to May of 2020, the Healthy Minds Network and ACHA, American College Health Association, found students were finding it a little bit more difficult to access mental health services. And that makes sense because that was the beginning of the pandemic and we were all scrambling to figure out how to do business differently. The other thing that you see on this slide is that students were finding that they were more impacted by their mental health symptoms, which obviously impacted their academics. Next slide. So these two studies show that in 2018, 2019, counseling centers were doing really very little of telehealth, and that college health and counseling are often challenged with needed resource allocation and financial constraints. Next slide. So fast forward to fall 2020, and here we see some statistics that verify that most of us in college counseling are doing telemental health, and that a few were going back to pre-pandemic status, but again, the majority are kind of in the throes of doing telemental health. Next slide. So the benefits of continuing telehealth, and there's many, these are just the ones that I think are predominant. Improved access to care, it really does lower the bar, increase help seeking due to some of those decreases in barriers. I think stigma, again, that looks differently because students can access services in the convenience of their home. It's safe for staff and for students. We see improved attendance, so less no-show rates. Client satisfaction seems to be improved, and there is access to specialty care, especially important in rural areas. Next slide. So talking about some challenges, interjurisdictional laws, reciprocity across state lines, we've all been dealing with the caveats of that. Just missing the shared presence of being in the same room with someone else, that human energy, I think can be looked at as a challenge. It's not suitable for all patients. We'll talk about that in a few minutes. The strength of the internet, we're kind of at the mercy of that. And in terms of what our patients have in terms of their system and their internet availability, we do have to ramp up what we're doing in terms of HIPAA and privacy risk assessments. Insurance billing is variable. Most college counseling centers do not bill for services, but still, I think that's kind of been a moving target. And the need for ongoing training. And again, that's so important in the telehealth environment to keep that training consistently going. Next slide. So you see on this slide the three predominant accrediting bodies for college health and counseling centers. And I'm going to focus specifically on the Accreditation Association for Ambulatory Healthcare. Next slide. So the first standard for AAAHC is rights and responsibilities, or rights of patients. So patients are given the opportunity to participate in decisions involving their care, and patients are informed of their rights and responsibilities. So responsibilities such as they need to find a private location. I've done many sessions with patients who are sitting in their car. Internet access, camera and phone and microphone, an area with low distractions, appropriate attire. I've done many sessions with patients who come in their pajamas or men have no, shirt on. Agreement to provide crisis contacts, and that location is identified at each visit. And then obtaining consents in the virtual environment can also get a little bit dicey. If organizations have a portal, sometimes there's the ability to do signing of an informed consent or acknowledgement of informed consent through the portal, but we do need to find ways that we can get that signed consent form, and then authenticating the identity of your patient. And typically we're looking at least 2 patient identifiers. Next slide. So the informed consent is extremely important in the telehealth environment, and you do want to have included in your informed consent the information that's listed on this slide. So scope of services, any limitations to privacy, so things like internet breaches, accessing services with unsecured networks, restrictions on recording and posting. You do not want to see a recording of your session uploaded on Instagram, for instance, and alternatives to virtual sessions, and those need to be outlined for patients. The benefits and threats of services, information related to the disconnection of service. So if you're on a video conferencing call with a patient, what happens if the internet goes down? Emergency situations. So typically we look for consent for at least 2 emergency contacts. That way, if one is not available, you do have another one to contact. And then methods of communication between sessions. What is appropriate? What are you allowing? And then obviously conditions to breach, which would be a part of every informed consent for behavioral health. Next slide. So chapter 2 talks about governance or leadership. And here we look to see that there's been approval of all of the policies, procedures related to the telehealth environment. We'd also want to make sure that your governing body has oversight over your risk management program. Next slide. And I want to spend the most time kind of on that risk management piece. So policies and procedures are needed to address the potential threats to the security of client data and information when using telecommunication technologies. Risk management policies should be updated to reflect the need for thorough documented risk assessments specific to telehealth. So it should outline the process for the documentation of administrative, technical, and physical safeguards, as well as mitigation plans and breach notification processes. The need for business associate agreements and a HIPAA compliant platform, and also surveillance mechanisms. You'd also want to make sure that you have directives on things like password sharing, and also having passwords in unsecured locations and forgetting to log off computers. Audit processes regarding things like login failures and attempts, and system for auditing, chart processes, and access. So data storage security as defined by HIPAA includes encryption of stored data and storage of PHI on devices, including those that are physically outside the organization. And those might be laptops, flash drives, mobile devices, and policies should really articulate if only organization provided devices will be used, and if not, staff should really be encouraged to use things like a VPN system. Making sure that the end-to-end encryption meets the federal information processing standard of 256-bit, and the policy should address a mechanism for storage, retention, access, and destruction of electronic communications, and things like text messages, emails, etc. Next slide. So this slide talks about quality of care, and here we're looking at the fact that healthcare needs to be provided in a consistent manner, in line with the standard of care. And you would want to pay attention to things like patient selection. So inclusion criteria, exclusionary criteria. It's important to know that all of these things that are listed under patient selection, clinical judgment needs to play a part in that. And there's really no hard and fast exclusionary criteria. It's really based on clinical judgment and the needs of that patient. But you would want to consider things like cultural issues, complex cases, maybe crisis-oriented type patients. Individuals with thought disorders may not do quite as well in the virtual environment. Body image issues. I have a number of patients who really have trouble with the camera part of it. Patients might not have a secure or private location or internet access. Modalities of care. So sometimes things like EMDR, hypnotherapy, Gestalt type strategies, role play, they may not lend themselves quite as well to a telehealth environment. And then those patients who just have fears related to safety of the internet or the platform to use. And again, they may not be the appropriate candidate for telehealth. Next slide. So along with quality and attention to quality comes emergency management. So here you'd want to identify crisis management resources where the patient lives, and also partner with community resources where the patient lives. You do want to obtain at least 2 emergency contacts, or some organizations call it collaborators. And you would want to confirm location and emergency contacts at each visit. You do want to consider exclusionary criteria. So again, if you have a patient who is just very crisis oriented, and that seems to be the case more than not, that patient may not be appropriate for telehealth. Next slide. So chapter 6 talks about clinical records and health information. And here we're talking about things such as unauthorized access, retention of records, and also protection of records. Next slide. And I wanted to spend some time on documentation requirements for the telehealth session. So you would want to document the session type. Is it synchronous, asynchronous? The platform used, is it HIPAA compliant? Verification of patient identity, again, 2 forms. You'd want to identify that the consent form was reviewed and that the patient confirmed their location and was in a private space. You'd also want to confirm that emergency contact information was reviewed. Again, that's important because it can change. And then permission for anyone else in that area. And you might need to actually ask the question, is anybody in earshot? Because if you just ask, is anybody in the room with you? They may say no, but you do need to get permission from the patient for anyone that can hear the conversation or the session. And then alternate contact method has been confirmed. Next slide. So this slide talks about a variety of policies that either need to be revised probably or developed or just looked at related to telehealth to make sure that you're in line with being compliant with what's needed in a telehealth environment. I won't go over them, but the slides will be available after the presentation. Next slide. And this is again, just additional more policies that you really just want to take a look at. Next slide. So let's look at the future direction of college counseling, and it may kind of be business not as usual. Next slide. So when I think of the denominator for the future related to college counseling and telehealth, I think about three main concepts, and that's improved access to care, just-in-time care, and also providing diversity of services. So virtual platforms allow us to improve the access to care. You want to make it easy for patients to receive services. Things like web appointment scheduling or drop-in options are examples of that. And then just in time refers to timeliness. So providing services as needed without waits. The origin of just-in-time care really comes from Toyota, who created a production system where parts arrive to the warehouse exactly when they're ready for distribution. So just in time. And by doing this, Toyota was able to significantly reduce the amount of inventory that they had just laying around. So on-demand, same-day appointments, short wait times for the initial appointment, same-day triage, these would all be examples of that. And then providing diversity of services, and some people call it stepped care, and that's providing the level and intensity of services based on the patient's acuity and need. And here we want to see a menu of options, which might include things like short-term focused therapy, fast track, skill development groups, case management, virtual chat sessions or check-ins, self-management tools such as apps and web-based modules. And these all can be provided both virtually or in a hybrid type model. And again, just trying to meet the needs of the patients in a way that makes sense. Next slide. So in conclusion, and these are some of the things that I reiterated earlier, you'd only want to provide clinical services that you're competent to provide, ensure multicultural competence and attended linguistic and other diversity issues in your interactions with clients, and very important to follow all duty to warn and mandatory reporting requirements in the jurisdictions where you are providing services. Next slide. And this is the last slide, and I just wanted to reiterate, again, going forward for the future with mental health and college counseling, we want to make sure that we advocate for things like license reciprocity with licensing boards. We want to make sure that we're clarifying student need, demand, and report on outcomes to substantiate continued need and continued resources. And then also satisfaction of survey data. You want to make sure that you're gathering data on satisfaction data, utilization data, outcome data, and thinking about quantifiable measures and making sure that you're always kind of linking those quantifiable measures to things like flourishing scales and also retention. Next slide. And I think we're ready for any questions.
Great, thank you, Joy. That was a wonderful review. I see just one question in the Q&A, but I actually want to save that for the whole panel. So we'll skip that one, but I do just have a couple of my own questions in the 1 or 2 minutes that we have. The first is that you cited this ACHA data at the beginning, that 23% of students are really having a very difficult time accessing mental health services. Do you have any indication that we've improved from that benchmark?
Well, I don't have study data. American College Health has done, I think we're up to 4 surveys of our students related to telehealth. And, you know, I think in those early days, March through May, we were all, I think, scrambling to figure out how to provide services. Campuses were closing, things were going completely remote access. And I think colleges were really trying to figure it out in terms of how to provide services differently. Many of the college counseling centers did not have any experience with telehealth, did not have any idea with platforms. And so there was a learning curve there. And I'm sure it's better now, as the slide showed in terms of the latest data related to telehealth, fall 2020, you know, most of our schools are providing that service.
Great, and just one more quick question before I introduce our next speaker. On the same slide, you mentioned that an increasing percentage, up to 30.5% of students are actually saying they're having trouble with their schoolwork. What types of considerations regarding grades and advancement through the curriculum are relevant for the mental health providers?
Yeah, I think mental health plays a vital role, obviously, in the academic setting. We know that the welfare of the students, the mental health status of the students greatly impacts their educational efforts and what they can do in the classrooms and academically. So we tend to partner a lot with academics to help them with identifying those students in distress, getting them the right resources they need, teaching them how to not only identify, but intervene and refer appropriately, and making sure that on the syllabus that's given out to students, there's information and resources for students to contact and access the services they need.
Great, excellent point. Well, thank you for that. And please stay on as a panelist. We will have some time for Q&A later. It's my pleasure to introduce our second speaker. If you could open your video up, Jay, there you are, all right. Jay Ostrowski is the CEO of Behavioral Health Innovation, where he develops and deploys telemental health, telebehavioral health, and tele-MAT programs and designs HIPAA-secure software applications such as adaptive telehealth. He also serves as a telehealth consultative and implementation partner for the Mid-Atlantic TRC, and is the director of the Telebehavioral Health Center of Excellence. Jay, over to you.
Hey, thank you very much for having me. I'm glad to have you guys on here. I've spent quite a long time setting up colleges for telehealth and helping them get going and improving and solving new problems with that. Pandemic has obviously created even more challenges. But we have, the good news is we have solutions for these challenges. And so I promise that we'll be sharing some of these today. If you're new, we're going to be sharing a good kind of basics set of slides. But these slides are a lot of information. This is kind of like drinking from a fire hose, I understand. So this is intended to give you kind of a quick preview, and then we give you a lot of resources at the end of this, and then continued help after this. So you're not alone in this. Many people have gone before you if you're new. I know many people started seeing people through video and messaging in the pandemic, and maybe they're wondering how to continue this in a sustainable way. And that's what we're going to be talking about today. Next slide. So just a quick overview of, there are hundreds of different types of telehealth if you start Googling it, and it can be dizzying and worrying, like, do I have the right information? So we've created the Telebehavioral Health Center of Excellence to help you kind of put the cookies on the bottom shelf, easy access to vetted information that's vendor neutral. But I want to give you kind of four quick buckets to put everything in. First of all is a text-based so anything to do with a keyboard, basically in an app or in chat or a forum. This is basically something that you would do with your keyboard asynchronously. It could be like in real time asynchronously or over a period of time. So that's one valid way of doing some telehealth. Another would be assigning clinical workbooks where you're asking students to do assignments and getting back their clinical information and then going over it with them in a session. It's a good way to kind of fast forward some of their progress. Obviously, video is the one that most people think of. You can do this in individual or groups. There's quite a few people have moved online to do group work, and that creates lots of good options. And then avatar or virtual reality. All four of these modes have have research behind them, and they're kind of good at different things. I don't want to go too deep into each one, but I want to kind of lay the table of these. These are, you know, some options for you. Next slide. You're probably already aware that you can do telemental health in many different scenarios, clinic to clinic, clinic to X, which could be, you know, to a school, to a prison, to a corporate setting, or clinic to client home, or clinician home to client home. Next slide. There's a lot that you can do, and there's a lot of good research behind it. So I just want to give you a couple of citations here, and then at the end you'll see a long list of more citations. If you need more, contact us, and we have a lot more research to give you if you need to substantiate a practice. Next slide. There are a lot of things you can do with telemental health, and these are just a couple examples on the screen here. You can do clinical psych assessments. There's nothing in the literature that is prohibitive of this. People cite not being able to smell somebody or not being able to see psychomotor agitation, maybe of their foot. In my experience, you're able to see this eventually in your clinical interview, maybe through pressured speech or other hand motions, things like that. Typically come out within a half hour of a video call. So I think you'll find that if you start doing these sessions, you'll find that that's quite amenable to that. The research does show that you know, clients really like telemental health, and actually there's a much lower no-show rate through telemental health. Providers, they're kind of tepid. We prefer in-person. I practice in 2 states, and I prefer in-person, but it's kind of hard for people to go from Michigan to North Carolina. So that's why I do this online. But you could do quite a lot of things. Clinical supervision, you can, you know, observe things. You can do group, medication assistant, medication management, a lot of different things. There are different protocols for these, of course, but again, a lot is possible through telemental health. There are several trainings. I'm going to give you a link to a training here in a few minutes. So it is good that you get training that's usually required by your ethics and your state laws. But there's no contraindications to telemental health that's in the literature. Even seeing suicidal or homicidal clients is now considered normal, because it's considered better to see them through video than to refer them to 911, where they don't really have access to care immediate. So you staying on the call while you're calling emergency services is a better way to go, and to really kind of talk them and have a continuity of care from their crisis over to another care provider. And then drug and alcohol cases are pretty normal now, seeing them through telemental health as well. Next slide. So there are a number of things that can go wrong, and I hate saying that, but it's definitely true. You could, you know, have a call set up, and I'm sure a lot of you had this before, where there's just nobody there, and you're waiting, tapping your foot, wondering what's going on. There may be a disconnection during the session, so maybe someone's electricity went out, or their computer died, or someone's battery went out. There could be a technical breach or technical problems. So because of all these different things, we create best practices and policies and procedures, as Dr. Himmel mentioned. And it's important that you create these policies and procedures. And if you're not familiar with what to do, you can connect with one of the telehealth resource centers, and we're happy to help you through that. A lot of this is on our websites, but I know there's a lot of information out there. So sometimes you just need a little bit of guidance of where to look, and we're happy to help you with that. But you need to kind of a workflow, and that's, you know, what do I do if this happens? What do I do to prevent these things from happening? And that's what good training will help you do, is think through all the scenarios, create a protocol ahead of time, and make sure that you're completely prepared. Next slide. So these are quick high-level requirements. I'm going to just show the slide and move on, because we want to get through all these slides. Next slide. So those are kind of the how to set up the practice and kind of high-level things to do around setting up a practice. And it's important to go through that checklist yourself, make sure that you have done that. All these slides are going to be available, and I know Danielle will be mentioning that in a little bit. But these are the best practices of what you need to do and make sure that you've done before a session, after a session. What I've done is kind of given you a list of 16 and then say, here's the type of activity this is, and then here's when I recommend implementing it. Obviously, getting training is a one-time thing. You'll get some continuing education as well. Some of the things are like giving them, verifiable credentials. How do they know that you're really a clinical provider, and having that public? But then every session you need to, go over a few things and make sure that you get their physical address. Let them know in advance that you're going to need a change of address because you need to be able to find emergency services local to the client. In training, we have people imagine that your client is suicidal and then slams the laptop closed, and then you're stuck there with a suicidal client, not knowing where they are. And so you need to know where they are, their identity, and who you're going to call if that happens. And while that's not very common, it is something that does happen, and we need to be prepared for it, especially depending on the volatility of your client base. But you want to be prepared. And I usually, once I have their address, I usually Google their sheriff's department in that area, and that usually the street address and the county, and then the county sheriff's department. So if you have this stuff on record before your session, that kind of, you can have an admin do that. You can do that yourself. But that kind of protocol of how you're going to be ready for an emergency, and then just chart that in their chart to be ready. And then if they're planning on being in a different place, you just ask them to tell you where they're going to be next time. So those kind of little routines of what you do before a session, what you do during a session, what you do after a session, where you put this information, that's all part of that policy procedure and that workflow that will make this helpful for you. Next slide. So state licensure laws have been in effect, but a lot of them have given you a little flexibility. So there's some states that are saying, if you have a license in another state, you can practice here too. But each state has a little bit of nuance to what they require, and you do have to abide by their state regulations. So that means their informed consent might be different, their parental consent might be different depending on age, or their a duty to warn and stuff like that might be a little bit different per state. What I recommend is limiting the number of states that you will practice in. There are states that have reciprocity and you can get another license. I've done that. Or you maybe want to just limit it in a few states or have different providers focus on different states. But be careful when you're doing this, and just be a little bit aware of that. And we have this information on our websites, the telehealth resource centers, to guide you towards finding the laws quickly, because it is a little tricky finding those regulations. The ethics have not changed though, so we are still required to keep our clients' information private and protected. So the HIPAA laws have not been waived, so to speak, but they said that they're not going to come back and enforce them for a period of time. They are expecting us to abide by HIPAA, and HIPAA, as you guys know, is a complex kind of thing. It's scalable, depends on your organization. So we do have some guidance on our websites for that too, of how to get yourself HIPAA secure. No technology by itself is HIPAA compliant, so know that you can't just rely on a technology to take care of all your HIPAA needs. It's always a combination of administrative, technical, and physical policies that kind of work together with a technology. And there are different definitions the vendors use for what secure really is. So we do have some kind of guidance on that if you need that. Next slide. Next slide. Okay, getting paid. There are different ways to get paid, and I don't want to go deep into that because some of you have different payment models. But if you did want to try to get a third-party insurance, most of them pay for HIPAA secure video, and some of them do pay for secure messaging and even IOP. So, and that's kind of some neat trends coming out of that. Next slide. So this is a really, really great resource that came out before the pandemic. If you want to go into billing. Next slide. So think about now that, go back one, please. So now that you've been getting your feet wet, think about sustainability in ways of if I get a higher volume, if I get a lower volume, if my staff gets sick, how am I going to measure these things? and having to document and even refer to other systems. So a lot of this will need to be HIPAA secure in the near future. And it's time to look at what's your software, what's your workflows that help you get there. Next slide. So you might want to look at moving beyond just hourly video work. If you're like a counselor, for instance, into prescribing certain HIPAA secure apps, or creating workflows that create homework, things like that that are done in secure environments. And look at automating as much as you can. Next slide. So what are the greatest indicators for success? And you might think, well, it's the technology, or it's a great clinician, or great internet. All those are very helpful, but research shows that the best indicator for a successful telehealth visit is the confidence of the provider. I know, the confidence of the provider, which means you need to practice what these workflows look like, and do them again and again, and get some feedback with your peers to make sure you have good lighting, you have a really good flow on how people are using this, and abiding by all the regulations, and collecting all the data that you need to collect in a timely manner. Just like when you first went into practice, you had some different ways that you had to learn, and different procedures or policies. Telemental health is the same way. Once you finally get the flow that you need and everything in place, it's a matter of kind of practicing your checklists and practicing this, and it'll become routine, just like your in-person work. But it does take a little bit of work up front. Next slide. So workflows are the second big thing that I would say is makes sustainability work. So workflows, if you automate the workflows to collect the data up front that you need, and the data during your sessions, these could be done in waiting rooms and intake forms that are all in a HIPAA secure environment. Next slide. And you need to think about what is for the client and the practitioner. What do the admin staff need? What does the billing staff need? What do your grants need to collect information? This is just a screenshot of one of the many platforms that are out there, where you could have a scheduling, and all the links are online. You're not emailing links or texting links to people. Everything is kind of in one place, where you have your timer if you want. So you want to schedule, reschedule, send documents, surveys, all of that can be in one place. And that's really what makes it efficient. So having the efficient workflows is going to make it more financially sustainable, and for you to see a bigger volume of people over time. Next slide. So these are just a couple screenshots, next slide, of assessments, different things you can do. Next slide, a referral process. Next slide, asynchronous programs like drug and alcohol, education, and assessments, even groups through group chat forums or group video. We have a resource here, that the tbhcoe.matrc.org is a place where we put a lot of this information in there. You can also reach out and get contact us for more information if you need help. Next slide. And then there's a link here to a webinar where we go through a kind of a quick 45-minute training on all the best practices and ways to set it up in COVID environment. Next slide. This is our MATRC site, and it has a lot of information for schools and for telemental health. Telebehavioral Health Center of Excellence is there as well. And that COVID gives you tons of COVID information. And I know the NETRC, the NCTRC also has, the NETRC, Danielle's firm, has a lot more information. Next slide. So I have open office hours every other Friday. If you want to reach out to me, it's on that MATRC site, and just click a link and start a video, and I'm there to answer questions if you need me. So all right, I'll turn it back over to you, Dr. Raymer.
All right, great. Thank you, Jay. That was a really nice overview. And I do have one question for myself. I think we'll share save the group ones for the panel at the very end. But you'd mentioned, that situation of someone who's suicidal slamming the laptop down, and what to do in that situation. That brings to mind that really the providers would benefit from training in these new modalities, new situations. Have you been involved in some training of providers?
Yes, I created the board certification in telemental health, where we had 9 courses for that. We do trainings pretty regularly. There's a link to a free training online. I I do agree that they should get training. It's required by their ethics, but also just to practice what the odd things that could happen, and also just for your professionalism and good patient care. There are little nuances in security and in how to go through workflows that can make it a lot better experience, both for the provider and for the patient.
Great, thank you. And I know you had a couple resources. I tried to put one of them in the chat. Please feel free to put any other links in there to share for our participants.
Okay.
All right, thank you. So let's move on. We're just about on time. So I'm pleased to introduce Kathy Chorba, our third speaker. She has 24 years of telehealth program development experience, beginning at UC Davis at their telemedicine program, and has also worked at the Center for Connected Health Policy as the Director of Specialty Care and the Safety Net Initiative, implementing telehealth services in 5 University of California systems and 45 safety net hospitals. She is now with the California Telehealth Network as the Executive Director for CTRC. So go ahead and take it away.
Thank you, Dr. Ramers. Hi, everybody. Next slide, please. So basically, this presentation is for those of you that need to import specialty services because you don't already have the service available, or if you need extra assistance with tackling patient volume, this presentation is definitely for you. So finding specialty service providers is not as difficult as it has been in the past. I'm sure you probably have found that. But the real challenge today is identifying those that can meet the unique requirements of your organization as well as your patient population. You might want to consider asking your potential partners a few of the key questions that will be included in today's presentation. Next slide. We've divided the questions into 4 key categories. One is getting to know the provider group and defining expectations, setting communication terms, and support considerations. Next slide. Each provider group will have different policies, procedures, credential preferences, and billing models, all of which are important to understand before making a final provider selection decision. Next slide. So let's start off with our 20 questions. Some providers will offer one specialty only, like behavioral health, and other providers offer a wide variety of specialties that include behavioral health, because in a clinic model, you're going to need more than one specialty for your patient's needs. Some clinics they like the one-stop shop for all of their specialty needs, which means they'd select a service provider that offers multiple specialties. And that simplifies the contracting, credentialing, and referral process and workflow. And other clinics do prefer to shop around and find the best price and/or service for each individual specialty. Next slide. Another question would be credentialing policy. By proxy or full credentialing will make a difference in how fast you can bring a specialist on board. If you're billing on behalf of the specialty provider, you're going to need to bring them into your 4 walls, and you'll need to credential them at your site. Some specialty providers will utilize credentialing by proxy, while others will accept your wishes if you would like for full credentialing. In addition, you're going to need to keep in mind the specialty providers will need to be credentialed with the patient's health plan if you're billing a health plan. Next slide. Referral guidelines are an important communication tool that specify the time required for new and follow-up patients, or if or when a provider should be in the room during the consult, and the information that's needed prior to the consult, such as labs, chart notes, questionnaires, and other valuable things. This is helpful so that you know the exact requirements for patient referral, as they may vary depending on the specialty and the individual specialist that's providing the service. Next slide. There are also several billing models that are used by specialists and provider groups, and it's important to discuss these and establish a model that is mutually beneficial in advance. This is going to help you to determine the financial model that best fits your program. Next slide. Depending on the specialty services needed, as well as the volume and modality, each rate and modality for each specialty, the rates are going to vary. Rates for store and forward specialties will typically be lower than live video specialties, and new patient appointments may be more expensive than follow-up appointments. So keep in mind, if a specialty group bills by the hour, it's important to know the time required for new and follow-up patients. And if the specialty group bills by the completed encounter, then the rates are going to be, they probably will be higher than the hourly rate. Next slide. Just like hiring any new staff member, it's important to find someone that fits within your organization's culture. And it's also helpful for the specialist to know what your expectations are of them, as well as it's helpful for you to know what the specialist's expectations are of you. So the 9 questions that will follow may help you to clarify these roles. Next slide, please. Some specialists will have a preference. If you're doing a clinic-to-clinic model, they'll have a preference and they may not be willing to let you determine who presents the patient to them. Some specialties like behavioral health will not require a provider in the room during the consult. So it's important to agree in advance how much time they will require each type of staff member to be in the room. And this is handy to know for staffing, scheduling, billing, and budgeting purposes. Next slide. Timeframes will vary for each specialty and also the specialist providing the service. Most specialists require 40 minutes for new patients and 20 minutes for follow-up patients. But for mental health, it may differ between pediatric and adult. And so it's important to know this when the billing model is to pay by the hour, as you're going to need to structure your appointment schedule strategy to ensure you can financially afford the specialist time. So let me ask you a question. So next slide. When you're paying the specialty service provider by the hour to provide services for you, when is the $250 an hour specialist less expensive than the $200 an hour specialist? And on the next slide, the answer, of course, and you probably already know this, is when the $250 an hour specialist can fit more patients into each hour. So the next slide will show you, this is where the hourly rate and time requirement for visit type questions are especially important for the FQHC and RHC clinics that may be listening into this talk. And these are for the clinics that receive a PPS rate for patient visits. So for those FQHC and RHCs that are interested in using our sustainability worksheet, you can download it from our website or give your telehealth resource center a call and they'll be able to help you. A lot of the clinics contact us saying, yes, but can I really afford to offer this specialty to my patients? Next slide. Why would you ask an onboarding process question? Well, some provider groups may offer training on patient presentation techniques, training on the referral process, training on equipment utilization and basic troubleshooting, and they may also provide video meet and greet sessions with the specialists and the referring providers. And some or all of these may be available at no cost to you, but some others may come at a small charge. Next slide. Maintaining your relationship with the same specialist helps you feel confident of what to expect and also assures continuity of care as it pertains to diagnosis and medication prescribing, especially for the behavioral health specialties. And having the patient be comfortable and have formed a relationship with the same specialist goes a long way in establishing trust and compliance with treatment recommendations. Next slide. Each specialist may have a different policy on handling patient no-shows and cancellations. And it's important to know upfront if you're able to cancel or reschedule patients and what, if any, that financial responsibility may be. Next slide. And knowing that there are often no-shows with patient appointments, most specialists will allow and or expect you to overbook patients. And they will most likely have some guideline as to how and what booking models work best for their telehealth clinics. Next slide. Question about direct patient care versus consultation only. This is one that comes up a lot. So direct patient care implies the specialty provider will make a diagnosis and treatment plan and prescribe medication independent from the primary care provider. With the consultation only model, the specialist will send treatment recommendations to the primary care provider, who will then be responsible for prescribing medication. This is really important to know since you want to discuss this with your providers to see if they feel comfortable prescribing a medication for a patient after only reviewing the specialist's notes and recommendations. We've seen this over and over again with lots of clinics and facilities that didn't realize that they would be responsible for prescribing, especially for the mental health specialties. So the next slide is regarding medication refills. It's also important to discuss who's going to be responsible for medication refills and how will the prior authorizations be handled. Next slide. Something that we don't really pay attention to, but it's very important and it's very reassuring to you and your patients that they're able to see the level of education, training, and the affiliations or board certification of the specialist. This sample form that's shown on this slide is a patient handout that's been used to describe in plain language what to expect during a telehealth consult. And it also shows the credentials and qualifications of the specialty provider. We find that communication tools like these go a long way in making your patients more comfortable with telehealth, as well as reducing the appointment no-show rate. Next slide. So on the next 5 slides, we're going to focus on communicating between the clinic staff and the specialist. Next slide. The reason you might want to ask if the referring provider can call the patient before or after the consult is because sometimes a primary care provider may need to speak with the specialist without the patient present. So basically, if the primary care provider wants to consult with the specialist when the patient is not in the room, you need to figure out, is that acceptable and is there a cost associated with that? Next slide, please. You should also set an expectation up front with the specialist and hold them accountable for timely completion and transmission of all consult notes after the completed visit. And this is not only important for the maintenance of provider to provider communication for continuity of care, but it's important for billing purposes as well. Next slide. Let's think about staff communication. You'll need to address what type, when we're talking about a clinic to clinic model, let's think about addressing what type of communication, whether it's text or email or phone, that can be used when either the staff has a question or if the specialist needs the staff to step into the room at any time during the consult. And this information is useful in order to provide the coordinator the proper tools for a smooth flowing clinic. One thing that we always want to keep in mind is oftentimes these clinic coordinators are not issued cell phones, or the room where the telemedicine equipment is located isn't near a station that's equipped with a desk phone or a computer. So how are you going to get information back and forth between the specialist and the coordinating staff as to whether you need someone in the room or you need to end the consult? So next slide. This question helps you to identify if calls, emails, text messages, or flags in the patient's charts are acceptable. And can these items be communicated directly from provider to provider or only through a third party, such as a scheduler, coordinator, or a receptionist? So the next slide. So let's go ahead and shift gears a bit now and talk about technology support and backup plans. Next slide, please. While most primary care clinic sites and most healthcare facilities have some level of technical support staff available, very few clinics have staff that are able to troubleshoot actual telemedicine video, peripheral equipment, and/or broadband connectivity for video transmission. So it's good to know that some specialty provider groups provide a basic level of technical support or troubleshooting assistance in order to make sure that these services are provided as scheduled. Next slide. And then also as a final slide, it's important to discuss a backup plan in the event of any technology failure. So the questions you need to ask are, what is the procedure that the specialty service provider follows should the video conferencing software disconnect during a session? How many attempts to reconnect should you make? Should you call the specialty provider's office or will they call you? What's the process for finishing the appointment or even rescheduling the patient should you not be able to reconnect? All specialty service provider groups should have a policy for technology failure. Next slide. So that was a brief overview of the 20 questions that you should think about when starting a telehealth contract or a relationship with an external specialty provider. And also to download these 20 questions, feel free to visit our resources page on the website caltrc.org. Next slide. And for more information, of course, and assistance with your telehealth needs, please feel free to contact your regional telehealth resource center. And thank you for allowing me to join you today.
Thank you, Kathy. That was a great overview. If we could have the panelists bring their video back on. I love that you finished with, we're here for you. That's basically the whole idea of this whole thing. I'm going to put just the general telehealth resource center address in the chat for people to connect with their local resource center. So we've got just a minute and a half or so for questions. There's one that did come in through the chat, or the Q&A, which has to do with engaging new clients or new students that have not really been your clients before. And I know, Joy, you addressed this a little bit, but could you just say out loud kind of what you mentioned here in the chat?
Yeah, so again, I think what we're trying to do here is normalize telehealth, telemental health. And I think there's a process there. So marketing efforts, I think, need to be employed. When you do marketing, what we're really trying to do is social norming related to telehealth. So using kind of high profile, maybe students on your campus to deliver that message, I think helps with just the social norming of it.
And Kathy or Jade, any other advice for trying to engage people who haven't really used this modality before?
Yeah, I think the short answer would be to ask them to give it a try. Ask if there's any specific concerns that they have, and then obviously address them and say, why don't we just try one session and see how that goes? Most of it is the fear of the unknown. And then once they try it and see, well, this wasn't half bad, or they realize that it's better than they expected, they'll probably continue. And that's, in my experience, been the case.
There's some amazing video clips that are out there on all of the TRC websites that speak directly to patients about what is telemedicine, what to expect during a consult. And I think that goes a long way in dispelling some of the myths that this is going to be broadcast on Channel 6. And also for primary care provider buy-in and specialist buy-in, we encounter this all the time where people say, this is not going to work for me and for my patients. What we find is to connect them up with a peer, someone that is already doing this and has a lot of experience, and to let provider to provider speak.
Great, thank you. Well, we've covered a lot of information. Hopefully this was just a sampling of things for you to explore later on your resources, and please do reach out to your local TRC for further help. Danielle, I'm going to throw it back to you to close the session out.
Very quickly, thank you so much, Dr. Ramers. Thanks to Kathy, to Jay and Joy. Wonderful, wonderful information. Thank you all for sharing your time with us today. We know you're busy, and so we appreciate you sharing it with us. Please join us for our January sessions. They are focused on pandemic response, best practices, and lessons learned. Same time, same place, 11 a.m. to 12 p.m. Pacific time. And just a reminder, please complete the evaluation at the end of the session, particularly for those folks who need CMEs. We really need you to fill that out. That's required. So with that, it's 3 p.m. on my clock or 12 p.m. on your clock. And so we will close it out there. And again, thank you so very much. We appreciate your time, and we'll see you in January.
Thank you.